My name is Steve Coe. I'm the Chief Executive Officer of Community Access. And my assignment, I have about 15 minutes to draw a line between the history of our organization, what we're about, how our philosophy towards treating people with mental illness has evolved and brought us to a point today where we're talking about engaging the youth in hopefully changing the world for a better place.
I need to pay my bills. I need to get a job to pay those bills. Will I be happy with this job? What's the point of getting a job if I'm not happy? What's the point of anything if I'm not happy? What's the point of anything, period? That was me at 10 years old, sitting in a classroom biting my nails down until they bled. And that was me at 19 years old when I experienced my first break. High school was particularly rough period for me. The emphasis on going to college and adulthood validated my anxieties, and by the time I graduated, I had become a ball of stress, anger, and self-loathing. I had a therapist and was prescribed medication, but by this point I was convinced I wasn't even worth the effort to get the help. I was able to tolerate one semester of college before I began to break down, and a few months later I was ready to end my suffering. Fortunately, there was a concert that I really wanted to go to, so I reached out to my therapist for help and was able to, go somewhere safe. I spent the next 3 months at Bellevue Hospital in a psych ward and discharged with the agreement that I would get ongoing care at a day program with some agency I had never heard of called Community Access. I was going to give the program, East Village Access, about a week, and when I fell back into old habits, I was going to move forward with that plan I had 3 months ago. 1 week turned into 2 weeks, turned into 5 years of getting support, acceptance, and the understanding that I needed. I was able to thrive because I was allowed a safe space to make decisions and gain insight into myself by reflecting on those consequences. Decisions like overcoming my anxiety to apply to a playwriting program and ultimately win the thing and go on to share the stage with Gabrielle Sidibe, Rosie Perez, and Seth Green. Decisions like applying to work at Community Access. Today I'm a peer worker at the Manhattan Crisis Respite Center, providing the same support and understanding that was offered to me. If that same 10-year-old nail-biting boy could see into the future, he'd rest easy knowing he can pay those bills, be happy, and find the purpose in life that he always wanted.
Just a couple of words about the state of mental health in general. Some of you may or may not know. I don't know that this year is declared by the World Health Organization a year dedicated to conversations about depression. Every year the World Health Organization actually picks an illness or a topic to focus on. So internationally, this is the topic of the year in the world of health. One of the things that they've pointed out is that there is more lost school and work time and more economic impact flowing from depression internationally than from any other illness. So, when people sort of brush mental health to the side, I think even now at the international level, health organizations are recognizing you can't do that. That it really is part of what needs to be considered. And, just one other point to put the broader issue in context. A number of years ago, the Institute of Medicine released a book on mental health care in children and teens. And one of the first points they made is that the biggest contributor to psychopathology in young people is poverty.
I want to first tell you a little bit about myself. As I mentioned earlier in a Q&A, I am actually a parent. I'm a parent, and I'm a Mac, so I don't know how to use this thing. So I'm a parent. I raised 3 boys, and my middle son struggled immensely as a very young child. And by the time he was 9 years old, he was suicidal. Now, I didn't know as a young parent this statistic. I didn't know that 1 in 5 children struggle from a mental health disorder. In fact, I would say what I knew was that A child's behavior is the result of parenting. And that's the world we all live in. That a young child's behavior, unless you are in the world of mental health, you do not know that a child's behavior can possibly be symptoms of an emerging mental health condition. And so my son struggled for many, many years. And we struggled as a family for many years before we were able to really get him the help he needed. What I know now is that his behaviors were emerging severe anxiety and bipolar disorder. I got to a point in my life where I decided we had to change the narrative. If we want to do something about youth mental health and improve the outcomes, we need to completely change the way our society sees mental health and mental health conditions.
So the Office of School Health, for those of you who don't know, the Office of School Health is a joint department. It's actually very unique between the Department of Education and the Department of Health and Mental Hygiene. And so Office of School Health does everything that's health related in our schools, everything from nurses and doctors, adolescent health centers, our vision program, oral program, etc. And then school mental health comes under that program as well. So how do we do it? We use a 3-tiered public health model. Some of you might have seen this. Again, it's a public health model. You might have seen this if you're familiar with PBIS, if you're familiar with other medical models. So if we look at the first tier, those are what we call universal services. Those are the kinds of services that we offer to anyone and everyone in the school. So you look at bullying programs, school-wide programs, teacher trainings, parent trainings and workshops. Those are universal interventions, open and access to all, referrals to outside agencies. The second is selective. These kids are selective because they're at risk. They're at risk for abuse, neglect, dropping out. Often these students are at risk of their behavioral or emotional challenges worsening. So one of the abilities through Thrive NYC is that we act early. Most of our interventions are preventive interventions that we do. Here's where you're going to see your group work, your restorative circles and justice, de-escalation, those kinds of interventions. And finally, the top of the tier, those are your targeted interventions. That's the direct service. So if there is a school-based mental health clinic on site, we're going to offer that. That's where counseling comes in. That's where crisis situations come in because it's targeted to that individual student and or their families.
So the Mental Health Commission of Canada is a national pan-Canadian organization, a non-government organization, and we're really charged with changing the mental health and wellness landscape for all Canadians. So we have a large number of initiatives that really focus on that. The Commission is 10 years old, so we're just entering the adolescence of our existence as an organization. And really over the last decade, we've focused energy in a few key targeted areas. First and foremost, developing and now implementing the National Mental Health Strategy for Canada. Prior to the Commission's formation, Canada was one of the few countries without a national mental health strategy. So now working on driving uptake of that strategy. We've developed and are quite pleased to be operating a world-renowned mental health knowledge exchange center. We operate Mental Health First Aid Canada and had the great fortune of implementing a huge national demonstration project over 5 years in 5 cities across the country to prove beyond a shadow of a doubt that a housing first approach can rapidly end homelessness for those experiencing mental illness. We've also spent the last 10 years really gaining a world-renowned expertise around stigma and how to reduce stigma. And when I say stigma, what I'm really referring to is discrimination. The discrimination that people who are experiencing mental health also experience, and a recognition that the root cause of that discrimination is really the lack of hope and the lack of belief in recovery. So very focused on instilling the knowledge that recovery is not only possible, but is certainly expected.
Hi, my name is Nixie Strazza. I'm 15 years old and a sophomore at High School of American Studies at Lehman College in the Bronx. For the past 2 months, I've been an intern here at Community Access, and I'm very excited about the opportunity to bring the values of Community Access and the Headstrong program to my school. Everyone knows that high school can be challenging. I know it has been for me at times, and many of my friends have talked about the difficulty of staying emotionally balanced in the midst of the pressures of school. But too often, students don't feel that they have the space to really express what they're going through. With this new pilot program, I'm hopeful that this will change. Following the lead of Headstrong's successful curriculum and Community Access's Changing Minds initiative, we want to create a school-wide outlet for students to express their real-life experiences with mental health and kickstart the conversation about ending stigma that surrounds mental health. With help from Community Access and the faculty at my school, I'm working to launch an after-school club that will share Community Access's and Headstrong's values on self-empowerment and give students the tools to tell their stories. The club will meet once weekly to discuss mental health issues in our school and neighborhoods. By promoting self-love and self-respect, we will learn that mental health is nothing to be ashamed of and that it is okay to speak out honestly.
I am, the program director at a facility for youth. And like my colleague said earlier, they talked about all the points I was going to nail on, right? One of the things that I've learned at my facility is the youth having difficulties transitioning from foster care to independent living. That's usually extremely difficult for them to do. And like my colleague stated, one of the things I think that the gap that's missing is addressing trauma. I'm sure it's traumatic to go from foster home to foster home to foster home. I think it's traumatic, and all the traumatic events from being in foster care to being homeless, and then all of a sudden they're in their own apartments. So that's what I face every day, is teaching everyday independent living skills. And also, as my other colleagues stated, to remove stigma. They have issues with talking about anything mental health. They say, oh, no, Selena, please don't do that. So I wanted to find ways to change the language so they're more accepting to their particular situations. And I think that's important, to change the language and to address trauma.
A lot of the Asian population does not know that there are mental health services out there that speak their languages. And, for us, I believe our biggest challenge working with the non-majority population, teenagers, is the stigma. And when I mean stigma, it's not much so like what the society views stigma toward our patients or clients who come in. It's more so the internal cultural stigma that the parents have. So a lot of our teens that we work with are second generation teenagers. They might not speak the same language, whereas the parents are the first generation, and they don't know English at all. And unfortunately, they might be working a lot. So when they think mental health for the parents do not understand why the children needs it, and our challenge is to educate the parents on it, because it's kind of taboo in most Asian cultures that we do encounter, whereas most of the adolescents we work with are very much westernized and they're very open to mental health services, while the parents are actually resistant.